Hey, hi everyone. No disclosures. Just a quick background. I know you guys have seen this slide probably more times than you can count, but we have over 60 centers of T1D exchange, and we're using the data to really help improve the lives of those living with type 1 diabetes. And kind of the background of my presentation today, we know that T1D progresses to identifiable preclinical stages, but this initiative that we're doing aim to improve early detection of stage 1 and stage 2. But in order to do that, we have to increase and enhance screening and monitoring efforts through educational coaches for endocrinology centers. The primary goal was to operationalize early stage T1D screening while using a quality improvement framework. For monitoring, individuals were eligible because they had confirmed stage 1 and stage 2 type 1. That means family history or program-specific criteria. But in order to really partake in this initiative, we really have to dig deep and see why do we have so many barriers and gaps in this, right? We have over 60 centers, but there's not a lot of logistics on it, protocol procedures on it. So why is that? And just to go through the fishbone diagram quickly, because it's a lot. So for policies and procedures, um, there was a lot of consistency guidelines on who should be screened. And then for product and technology, there's a lack of point-of-care kits readily available in various clinical and patient locations. And then for equity, right, either health literacy or educational materials and communication for those who may not be speaking English. And then for place and process, outpatient settings, local risk outreach diabetes clinics. Sometimes centers just can't have any outreach because either bandwidth or they just don't have the resources to do that. And then for people and staffing, for the endocrine team member, sometimes this isn't mentioned enough, right? There's over workload, bandwidth, maybe lack of funding for FTE, lack of education as well. So we really wanted to dig deep more and really I think our next main step was we had 4 centers apply this initiative, and Dr. Levin's Lurie Children's Center is one of those centers, and Indiana University, Texas Children's, and Children's National. And we asked those centers to identify at least three strategies for screening implementation, best practice strategies for incorporating type 1 T1D screening in a clinical setting. The first one was patient engagement approaches, followed by workflow changes, overcoming systemic barriers and processes, and then documenting screening for stage 1 and stage 2 in the EMR, which is a lot easier said than done, as we all know. And one of those specific aims was increasing by 50% for those screened and an increase of 30% of those monitored. But in order to really understand, we wanted to do focus groups. There were 4 different focus groups that ranged from 45 to 60 minutes. And we really want to understand the experiences of these clinics, the workflow changes and barriers that they're facing on a day-to-day basis when it comes to screening implementation. A lot of the centers range from new program developers to those of the existing infrastructures. And some of the high-level findings that we found through these discussions were centers were building a completely new screening program from the ground up. So they didn't have an infrastructure that already existed. It was something that was started, pretty fresh. And then administrative and scheduling support varies by center, and it's crucial to continue success of screening and increase capacity, and then increase provider awareness and ensure that screening discussions are happening outside of the project team is very necessary. It's always great to have initiatives and projects, but if you don't have buy-in from your team, it's often hard to get results. And the majority of centers are documenting early stages of type 1 and type 2 diabetes. For the center that is not yet, they're documenting if the provider discussed screening with the family or patient. Some of the barriers included inconsistent provider involvement, documentation practices, EMR limitations, and tropicimab access challenges. And kind of the main reason for these focus groups as well is because I always ask, is it possible for a rural center in Montana, Oklahoma to take these initiatives and implement it in their center without seeking a significant amount of funding or resources to do so? And then some of the results here, centers reported that they dedicated clinic time expanding staffing, for example, for phlebotomists or CDCSs, EMR documentation tools, provider education significantly supported screening implementation, patient engagement materials, provider-facing dot phrases as well. And the new visit types were also developed too. Then the conclusion, we found that integrating early stage T1D screening into routine care is achievable through a structured QI support and educational support system. Clinical teams identified several best practices, strategies, and systemic obstacles, offering a foundation for broader implementation. And centers develop clear guidelines to determine who exactly will be screened, include specific criteria, um, who they will see in the clinic, a referral system, and also tracking tools as well. Then additionally, staff added a dedicated phlebotomist and more CDCSs to really support patients in this process and give them an understanding of the importance of screening and why it's necessary as well. And lastly, just references. Thank you.
All right, awesome. Now we will open up the floor for another 4 minutes of questions. All right. Yeah.
Hi, thank you. I'm Lorena. I have a question regarding teplizumab. How have you arranged the infrastructure to cover for weekend infusions and all of that?
Yes, I will give that to either Dr. Chaudhry or Dr. Levin.
So we've set up the infusion center in our Plano campus, which just expanded. So we were lucky to have space there. And it is covered by nurses who do other infusions for rheumatology and GI. So they are very experienced. And this is 14 consecutive days, including the weekends. So they have provided us staffing for the weekends as well. Yeah. We've had 100% coverage so far, including a patient with Medicaid. I had to do peer-to-peer for 3 of my patients, 3 out of 5. But overall, we've had good coverage. This is for stage 2. If they meet criteria 2 or more with dysglycemia, we've received coverage. That's not a part of the original definition, so we don't use that. We use other modalities. So in the state of Texas, we were told, or maybe it's universal, but every insurance has their criteria. So if that insurance needs an OGTT, we've been doing that. We've started using CGMs lately, and we've been seeing some really high numbers on some of those. So, not to answer your question, not using CGM for dysglycemia.